So, good morning, everyone. I'm very loud, so I'm not even going to stand by the mic. I think I love this venue. It's so much friendlier than people sitting in the classroom. And I also want to give a word of warning. There's some of you, like Greg and Kaven and Jeannie, who's heard me talk about this so many times that please close your ears. But for the purposes of those who have not heard the introduction about PBM, please indulge me. For those who have heard some of these things, please indulge me and sit quietly and let others learn. There is not very much in terms of developing in patient blood management. We keep talking about the same things. And maybe one of the reasons why we keep talking about the same things is because we're still having difficulty translating what we have known for a long time. So, and I'm going to point out some of the pitfalls of how PBM can be implemented. So these are my learning objectives: basic concept of PBM, essential strategies, review literature, as well as concentrate on benefits and cost effectiveness. These are my conflicts of interest. The most salient one is that I have accepted reimbursement of travel to Malaysian National Transfusion Congress from Octa Pharma. That was just recently. So what is patient blood management? So there have been, for the longest time, a BMM definition, a WHO definition, and then there is this global definition, which I actually quite like. And I'm going to highlight a few things from here. Patient-centered, systematic, evidence-based, with the idea to improve patient outcomes. And the whole point is to conserve and optimize patients' own blood. WHO has urged to implement this as a standard of care. And I absolutely love the wording of based on the scientific, economic evidence, as well as respect for the fundamental principles of ethics. Very well said. It is about the patient and about empowering the patient and giving them the best possible care. A little preview, we recently did an international forum. Some of you may be familiar, it's usually published in Vox Sanguinis and involves representatives from many countries. So this one was 16 respondents from 16 different countries covering all of the WHO regions. And interestingly enough, the penetration of PBM is very good. At least one PBM intervention has been implemented by all in their institution. What was surprising is that only half had a formal program. And what was even more telling is that that half was all high-income countries. So Australia, UK, Canada, not United States, surprisingly, and it was virtually unheard of in countries who were low and middle income countries. And they were citing a lot of barriers, including lack of knowledge, but I think the most salient one is insufficient resources. The attributes of patient blood management, in order to make it as effective and as beneficial as we would like it to be, would be first and foremost to personalize care to a patient. And that's not just about the preference, but also their comorbidities and the planned treatments. It has to be timely, and we have definitely a problem with this in Ontario. It has to be comprehensive, and it has to be equitable. So everyone should have an ability to benefit from this. You've seen me talk about this before. I'm very proud of this work. If one way to empower the patient is to educate the patient about anemia and its consequences, as well as teach patients on how they can make an improvement in this, including being involved in patient blood management and asking for a patient blood management consult. So you can watch the video. It's freely available on Vimeo. It's about 2 minutes long, and it takes multiple patients through their journey of going for surgery and through a patient blood management plan. You have also seen the slide. Many of us present something very similar, and it always sounds like a mantra. And there's no opportunity, just because of the purposes of short time, to go into this in detail. But anemia is common, and you're going to hear a lot more about this from Greg and other presentations later today. Even mild anemia may lead to adverse outcomes and increased healthcare expenditures. Anemia is associated with increased risk of transfusion, and for many countries, that means your patient may not have access to blood or may not have access to safe blood. We are lucky because this is not a problem that we generally face, although we periodically do go in shortages as well. And transfusion may be associated with adverse outcomes and increased healthcare expenditures. PBM usually is recognized as having 3 pillars. If you just think about PBM in general, not in terms of operations, it's all about diagnosing and managing anemia, minimizing the bleeding, and finally, if you're going to use blood, use it optimally. In the context of perioperative medicine, it becomes much more complicated because so many more interventions can be implemented, and that's the very, very expanded pyramid there. So let's talk about this. And as I said, I'm going to just give you a taste of some of these. The most important thing is to diagnose and manage anemia. And the most common tools that we use are iron and erythropoiesis-stimulating agents. And this is what OnTrack does. So OnTrack is a provincial Ontario patient blood management program, has been in existence for 20 plus years, and it really concentrates on pillar 1, which is let's identify anemic patients before they go for surgery, let's intervene, and of course, how do we know that the program is successful? You have to collect data on interventions and outcomes, and they use this publicly available algorithm on how they approach anemic patients. I'm not going to talk about iron. I know that there are some great presentations coming up about iron. Suffice it to say, there is an oral iron, there is an intravenous iron, and it really is dependent on how much time you have, costs. You also have to consider compliance and access. We all have struggled with our patients not being able to have access to intravenous iron depending on where they live. Drugs are available, and there is really, really good body of literature supporting the use of iron. Again, I'm going to leave it to Greg. I know he's going to spend a lot of time talking about it, and I don't want to repeat each other. Erythropoiesis-stimulating agents have been used for a long time, and this is the last systematic review, and you've seen me show the slide. The use of ESAs in major surgery is associated with reduction in transfusion rate, and there is no signal for increased thromboembolic complications, and that's important. What you see on the side, me writing it out, is essentially what we in OnTrack sites in Ontario usually do. And I want to highlight that this is a very personalized approach to the patient. So only major surgery, only anemic patients, and be judicious in the use of this very useful medication, but also a medication that in large doses has been shown to be associated with both venous and arterial thromboembolic events. What is not to do is this. So Cynthia is a friend of mine, so she'll forgive me. But I think this is not a good study. This is not the way what I would approach PBM using ESAs. So this study was for elective total hip and knee replacement surgery. It's now quite old. And what they found is that with their recipe, there was a 50% reduction in transfused patients and some non-significant reduction in red cells transfused. But they found that there were significantly increased costs. In fact, the conclusion of the study was the cost was unacceptably high, and in fact, the follow-up study was on how to successfully de-implement this low-value strategy, which essentially was trying to convince people in Netherlands that you should not be using ESA for arthroplasty. And if you actually look at the excerpt of what they've done, it was 4 successive doses of EPO, and you were only allowed to stop and omit the 4th dose if you exceeded the hemoglobin of 150 gram per liter. So no kidding, this was expensive, but also harmful to the patients. So this is an example of how you should not be implementing universal without any consideration of patients when you do this. So over the years, there were many things that OnTrack helped us learn, and some of them were, I think the most important lesson is lead time matters. We constantly have issues with lead time. We also have seen, and I'm not going to show you these data, these have been previously publicized, that multimodal, so many interventions are always better than one. In our setting, probably because our lead time is so short, sometimes in the matter of a couple of days, there is no possibility of oral iron to do anything, and so in our setting, oral iron unfortunately has very low efficacy. And most recently, we're very proud of this work. It was a work of one of our transfusion fellows, as well as many people from OnTrack and colleagues of mine, really emphasizing the need to prioritize women. Why? Because they're more anemic at all points of interaction in perioperative care, and they have way higher transfusion rates. And if you're interested, you can actually read our paper. Okay, pillar 2. Intraoperative patient blood management. There's a lot of things here that I, as a hematologist, do not care about, but I know that you who are surgeons, anesthesiologists, will know about the special instruments and the special anesthetic techniques and cell salvage and topical hemostats and types of surgery you can do to reduce this. But as a hematologist, what I talk about most commonly under this pillar is tranexamic acid. And I cannot emphasize the really, really good review. Nicole is here, the first author of this review. So if you haven't read it, it's freely available. Great review on tranexamic acid and in a very easy to read format. And again, this audience doesn't need me to tell you about tranexamic acid. Tranexamic acid, even 12 years ago, by this very immense systematic review, including 11,000 patients, showed that the probability of transfusion will be reduced by 1/3, and there was no downside in terms of increasing the risk of thromboembolic complications. Efficacy has been shown in a number of settings: trauma, postpartum hemorrhage, traumatic brain injury, and of course, all of you are familiar with the DEVERA study, POISE, published just 2 years ago, major non-cardiac surgery, a gram of TXA at the beginning and a gram at the end, resulting in reduction in major bleeding. So tranexamic acid is effective. And the reason I'm showing you this is ancient history, Greg, but the reason I wanted to show that tranexamic acid is probably one of the very few things where universal implementation may actually be a good thing, unlike ESAs, unlike iron, etc. Yes, you're shaking your head. Yes, there is GI bleeding, but I'm talking about in the context of surgery. So in arthroplasty, when we finally implemented universal TXA, it was allowing for very few opt-outs based on the medical history. So like, for example, a very recent clot. It didn't matter if you were anemic or not, what your hemoglobin was. You still benefited from this intervention. The other big one is stopping the bleed. We are big vampires. We love to draw blood from our patients. You've seen these before. If you're in the ICU, if you were not anemic before, you will be definitely anemic by day 3. And what is more important, it's not just the fact that we are wasting money and causing discomfort to the patient. We're causing hospital-acquired anemia, and hospital-acquired anemia has been associated with a number of bad outcomes, including mortality and readmission rates and longer lengths of hospital stay. And there have been many things trying to stop this from happening, choosing wisely statements, telling you, please don't repeat blood work if you don't need to, no routine orders, unbundle tests, stop routine draws. Tell MDs just about the cost of these things, and the cost both in terms of iatrogenic anemia, but also cost to the lab, cost of the fact that your turnaround time is increased for other really important tests because you're too busy running tests that should not have been ordered in the first place, or use computerized physician order entries, a mandatory review of order sets, et cetera, et cetera. There's also really good article plugging from St. Michael's Hospital on overutilization. But all of these things together are not seeming to move the needle. But what moves the needle is this, is switching to the small, so low vacuum, soft draw tubes, which do not impact your instrumentation, that are available and can reduce transfusions without impacting our ability to diagnose and manage patients. And finally, pillar 3, I literally just read it not as patient blood management, but more as an optimal use of blood. However, under that pillar, frequently forgotten are things like improving oxygen delivery, decreasing oxygen consumption. This is all I'm leaving to my anesthesia colleagues to do. But we can manage anemia post-op as well, same as we can manage anemia pre-op with similar set of tools. The most recent international guidelines that were led by ABB on this topic that actually used appropriate methodology and based their conclusions on evidence were these guidelines from 2023, and that body endorsed restrictive transfusion strategy for most patients. There was some disagreement about what that restrictive transfusion strategy should constitute, recognizing that different trials used slightly different thresholds. So I think the main theme is restrictive transfusion strategy. What that is, you can read the fine print for various populations. Now, after this, very shortly after this, MINT trial came out. And we know that the primary outcome was restrictive, was no worse. But the secondary outcomes are very suggestively pointing that acute coronary syndrome is probably one area where we should potentially explore more liberal transfusion strategies. It is too early to change practice, but there will be a statement coming out from this group to address this and acknowledge this. It's funny because during this we said there's equipoise, and it sounds like and this definitive MINT trial of 20,000 patients was going to be the answer, and we are still not quite sure about how to proceed from there. Of course, it's not just about adhering to a particular threshold. It's about using single unit transfusions for those who are not bleeding. So in other words, use the absolute lowest amount of blood that is necessary to appropriately manage your patient. So the last few minutes of my presentation, I want to talk about blood utilization cost and cost effectiveness. So again, even in this audience, last year I showed the systematic review, quite old, but that was the first attempt to systematically look at literature on patient blood management and see what is the benefit to the system. And the benefit to the system is reduction in consumption of allogeneic red blood cells, but also important clinical outcomes such as reduction in hospital lengths of stay, complications. And this one actually showed mortality rate, which has not been consistently shown by any other literature. So before we go on, if we were to summarize what we know, is that we know that patient blood management definitely reduces your utilization of allogeneic blood. And it saves you money because you have not transfused these units. There's also suggestion that some patient important outcomes have been improved, such as patients got out of the hospital faster, suffered less infections, spent less time in the ICU. Cost effectiveness is slightly different. So hold that thought. So I promised I will never put another slide on Western Australia, but here it is. It's probably by far the most commonly used slide in any PBM presentations that you would ever attend, showing these spectacular savings. But again, it's the same theme. We're saving allogeneic blood. That translates into cost savings, as well as we are seeing some improvement in infection, lengths of stay, and in this case, AMI stroke. This is Germany, more than 1 million surgical patients showing red blood cell transfusion reduction. And this is on track. You've seen this many times already, both in terms of reduction in red blood cell utilization, but also a reduction in infections, lengths of hospital stay, and savings in terms of saved blood versus savings versus the costs to administer the program, to have the nurses doing this, showing quite favorable picture. So you're not convinced that this only happens in high-income countries, because I showed you Australia, Germany again, and Canada. Here's Turkey. It's fairly recent, and I was drawn to this because it talked about cost effectiveness, but really they're just basically saying the same things. They've implemented patient blood management in their cardiovascular surgery department, and they saved a ton of money, 342,000 euros. Sounds like a lot, and they had less red cell utilizations and fewer complications. But let's talk about true cost effectiveness. So this is a true cost effectiveness analysis, 5 years old, out of Germany. So they did, first and foremost, in order to collect all the costs from a variety of places, they did a systematic review and meta-analysis of 22 studies, and this is surgical patients, both cardiac and non-cardiac. And they took into account costs of PBM interventions, transfusions, as well as management of complications, so sepsis, AMI, etc. And then they used a proper health economic model to calculate cost effectiveness of PBM. And what they found is that if you do not include hospitalization costs, the effects are marginal, but if you include the hospitalization costs, it actually looks like PBM is cost effective and actually coming out on top. So that was their conclusion. It may be associated with fewer adverse clinical outcomes compared to control, and may therefore be cost effective. Not to be outdone, their colleagues, also from Germany, did this study where they what they did is slightly different. They took meta-analysis of 17 studies, but they also took data from their own hospital in Frankfurt. And then they came up with cost-benefit analysis, and they calculated the cost of all the interventions versus the savings. And again, they looked here mainly at transfusions and lengths of stay, nothing else, no other outcomes. And the overall benefit was 21 euro, 60 euro cents per patient. So this is important. So what it means is that it's not like all of a sudden you're saving. It's so cost effective that we should all be doing this. This is an important theme because this really brings this point is value for money, value for patient, because we're not showing landslide savings, but it doesn't take away from the fact that this is the right thing to do. And now there is this. So this was published by NICE, which is kind of like our CADIT. And forgive my cynicism, I'm not surprised at the finding because it's coming out of such institution. So 400 randomized controlled trials, 55,000 participants. And the tagline is, patient blood management interventions do not lead to important clinical benefits or cost effectiveness for major surgery. In other words, delisted, defunded. So what's interesting is that one thing that I'm gonna show you some other data from this. Cost effectiveness. There was only one trial included under cost effectiveness category. Do you know what that trial was? It was a trial of using restrictive versus liberal transfusions, not even patient blood management. In cardiac surgery patients only, so maybe it's not cost effective in cardiac surgery, but anyways, it reads like it's not cost effective. Okay. And if you look at this, you will find that you clearly see decrease in the exposure to red cells. That's statistically significant. You will also see that without a doubt, patient blood management does reduce your ICU lengths of stay and your hospital lengths of stay. Unfortunately, all the others, mortality and AMI and all those other things, it's a wash. There's no significant difference that could be detected. And following publication of this, the good news is no one got defunded. OnTrack still has funding. I don't know what impact it had on our British colleagues. I actually was intending to ask them, but I didn't get around to doing this. But there were lots of editorials that followed afterwards and a lot of chatter on social media and other places. And this specific editorial, I do encourage you to read. It brings a lot of really important points. But I think the most important takeaway here is this value for patients. So you get out of hospital faster. Does it mean you return to your family obligations faster? You return to your work faster? Shouldn't that carry value because it improves the quality of the patient's life? The other really, really big problem is that it's very challenging. So we all understand that patient blood management is this giant old clock where multiple mechanisms work together, and that's what produces an impact. But it's very hard to study this. And it's different in different countries. Costs are different, reimbursements are different for drugs, et cetera. So it's very, very difficult to show this landslide cost effectiveness. So this is my last slide. Patient blood management is patient-centered, systematic, evidence-based. The point is to improve patient outcomes. It has these three pillars that we talked about. It definitely leads to a reduction in blood utilization and improvement in some patient outcomes. So the most consistent one is lengths of hospital stay. It may be cost-effective, but if it is cost-effective, based on what I've seen, it's not like a landslide victory for PBM. But I want you to leave with the thought that none of these studies have adequately considered what value patients place on this intervention. Thank you for your attention.